Well, I think we can get started. It looks like we've got a pretty full house. All right, so on our agenda today, we're going to explore this connection between trauma and homelessness, as well as discuss what's called the ACEs, Adverse Childhood Experiences. So try not to have too many acronyms for you guys today, but ACEs is one you're going to want to pay attention to. And then the bulk of what we're going to do towards the last hour and a half of our training is really giving you a new lens to see and interpret your client's behavior from, and then some individual level skills that you can start to employ with your clients. So we want to create some ground rules and make this a safe place to share. We are going to be talking about trauma, and those of you that may have also experienced trauma in your life, you may start to feel activated in your body. Maybe something we talk about is triggering. We don't know what's going to come up, but I want you to be committed to your own self-care today. How cool is it that you get to be here for 3 hours in this really cool room and not at your desk doing case notes or driving around town? So just take in this time to be present and take care of yourself. So this first section is just an overview of the statistics and kind of the context of what we know about trauma in the general population and then in the population of individuals who are unhoused. 61% of men and 51% of women report at least one lifetime traumatic event. So even just sitting here in this room, most of us have probably experienced something traumatic. I was in a really bad car accident 4 years ago and broke my neck and had a mild traumatic brain injury and was out of work for 2 years. So that's my big trauma. I carry it with me. It's here in the room, getting here, driving here, trying to park, getting activated, getting triggered. So just be aware that we're all sitting amongst and walking amongst people who have traumatic experiences. And then when we look at those who are accessing behavioral health and community healthcare settings, 90% of those clients have experienced trauma. So we know the people who you serve and work with every day have experienced trauma. And those that are homeless are 13 times more likely to be victims of violence than those who are housed. So that's just part of the trauma of being on the streets, of being homeless. Much more likely to be a victim of violence than actually commit an act of violence. Something else I want to bring up, many of you may have heard of Brené Brown's work around shame. Raise your hand if you know Brené Brown. Yes. I listen to her Netflix special often when I'm doing my self-care time. Highly recommend it. It's called A Call to Courage. So as a therapist, I'm very interested in how shame comes into play for all of us. We even have some shame around our experience in being a healthcare worker, a case manager, a therapist, of just how that shows up in your interactions with people. And when you think of being a homeless individual, many people have this sense of relational poverty where they feel so much self-loathing and isolation and loneliness and a lot of embarrassment about being homeless, that's often what can get in the way of them accessing help or services or reconnecting with family. There's an organization called Miracle Messages, which in some cases, it's with some clients, which is going to be important to know what you're dealing with in terms of adverse childhood experiences. But when a homeless individual's family member or members does not represent a trigger to their trauma, it's possible they could reconnect. And in this organization, 82% of referred families who've been separated due to homelessness wanted to reconnect with their loved one who was unhoused. So it's a cool organization to check out if you haven't heard of that already. They use the power of social media and connection to find family members and help homeless individuals sort of work through, get past some of the shame and not have so much of this loneliness and isolation, which is really one of the, when it comes to healing from post-traumatic stress disorder and trauma, not being connected to other human beings is really difficult to actually heal and get better and have less intense symptoms. But what we'll talk about further in the presentation is that when our bodies are giving us fear response signals and making us very afraid to trust others, it makes it hard to develop relationships. But I know from working with people like you guys are masters at building relationships and helping people feel safe and comfortable. I'd be excited to hear more from you on that. So with trauma, some people have just a one lifetime experience, others have multiple adverse childhood experiences. But trauma becomes complex when it builds on one trauma on top of the other. So just in and of itself, being homeless can be traumatic. And we know that many of these individuals have experienced childhood abuse, neglect, family separations, violent relationships, or witnessing domestic violence. So it's that extra level of awareness, which is why trauma-informed care is so important, because most individuals you're working with are going to fall in that category of having complex, multi-layered trauma that has built upon itself. So clients don't always see the world as a safe place or people as a safe place, and they don't feel like they can trust us. How many of you guys have experienced difficulty building trust with your clients? Raise your hands. Yeah. Huge issue to bring up, and being on guard makes it really difficult to ask for help and form those relationships. So the trust is really a big part of trauma-informed care, and we'll talk about how do we build trust through consistency and boundaries. Another thing to remember with this overall paradigm shift I'm trying to get you guys to have today is that you're going to start to look at behavior differently. Not just, oh, that person's acting out in the lobby, but why? What's behind their behavior? Why are they showing up as aggressive or withdrawn? To really look a little deeper instead of just responding to the behavior, because that's where we can get really burned out and stressed out, is if we're managing behavior and not always seeing what's behind it. Those of you that are parents probably can relate to this, right? Like when someone's having a tantrum, they might be tired or hungry. So you're always kind of investigating what's beneath that. Common behaviors that you might see from clients: withdraw from others, being aggressive, disassociating. We'll talk more about this later today, but have you ever been with someone where they look like they're just really checked out and spaced out, and they're staring into space and they're not really listening to you? Some of you might have experienced that yourself, especially when you're with a doctor and they're telling you something really scary about your health. They kind of start to sound like Charlie Brown's mom. It's just wah, 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 and you kind of feel like you're going above yourself and looking down at yourself in the room with the doctor. That's disassociating, that's checking out. Also, self-injurious behaviors such as cutting are really common with people who are living with trauma. There's other types of self-injurious behaviors like substance use. Maybe besides cutting, there's even, I think, forms of like over-exercising and staying too busy that are trauma responses, which I see a lot with clients and staff. I went to a training recently that said, the speaker was talking about that she used self-care to push past her limitations, not honor them. And I was like, oh, wow, that's huge. And I'm guilty of that. And being in the field for 15 years now, it's really easy to push past your boundaries and end up not really being helpful to yourself. So we'll talk more about that as we move along. So this is probably something that you guys are always trying to advocate and bring up at case conferences, team meetings, anytime you're interacting possibly with a medical provider, to really get people to understand that these client behaviors might appear ineffective or unhealthy, but that's the best way that clients know how to cope with having these traumatic memories, flashbacks, nightmares. Sleep can be horrible when you have PTSD because that's when it all comes back. And what we're really working on, especially in this program, is helping people to have housing, to feel safer, and to have healthier alternatives for their behavior and their coping skills. But we need to understand that what we're seeing presented in behavior is really the way the client knew how to cope with really intrusive thoughts, flashbacks, intensive symptoms. So actually, when we reframe that a little bit, it's kind of seeing that they were doing the best that they could, and given the situation and circumstances, and you're now beginning to show them these healthier alternatives. So when it comes to substance use and trauma, I always talk to my clients who are recovering from traumatic events. Will usually see an uptake in substance use right after a traumatic event. For example, drinking and doing drugs numbs you out, right? That's why people do it, and it actually is very effective in dealing with the symptoms of PTSD. Obviously, we don't want to encourage that in the long run because of the other health outcomes that are there. We've got to give clients resource and connection back into their body to cope with the stress, so they don't need to use as many drugs or alcohol if you're in a harm reduction program, for example. But again, it's what they've found. It's been effective. Can turn my brain off, I'm good. When my brain's not turned off, then I have to remember these traumatic experiences. And this is one I really want you to pay attention to when it comes to adverse childhood experiences, which we're going to talk about in the next section. If a client has 4 or more adverse childhood experiences, they're 10 times as likely to be substance dependent. We'll talk a little bit more about neuroscience today and how those early experiences really set up your brain to have difficulty with self-soothing and self-regulation. And that's another reason why people will find themselves dependent on substances. So you guys work a lot with the social determinants of health. I wanted to put this slide up here so that we could see how being connected with trauma-informed care and understanding what ACEs are really helps in this health impact pyramid of the points in where you're actually implementing trauma-informed care. Maybe when you're addressing just getting that initial housing set up, and then helping with case management to teach and model the behaviors of how to stay in that housing and maybe interact with other people if they've been really isolated. And then at the top of the pyramid is that counseling and education. And I'm a big fan of these pyramids and Maslow's hierarchy of needs. You guys are probably familiar with that as well. And that we're always wanting to, in trauma-informed care, provide space for our nervous system to get downregulated and relaxed before we can even take in information. So we're really building on meeting those basic needs, helping have a regulated nervous system. Then, oh, my brain's actually going to work the way it's supposed to. I can make it on time to an appointment or navigate a challenging situation, maybe even be able to go for some job training. Another thing I wanted to bring up in the context of all of this is that oppression also activates stress response. We had a couple people at the tables talk about working with marginalized and oppressed communities. So not only may you have a homeless individual who maybe has co-occurring disorder, mental health, substance use, childhood trauma history, what if they're dealing with racism in addition to all of that and their intersecting identity, or homophobia? What if they're interacting with a healthcare provider that has a bias towards them and they can feel that? One of the things when you've experienced trauma, there's some positive things that can come from it because you're very aware and of reading other people. And we'll talk about when that gets problematic, but clients pick up on it if someone has a bias towards them, if they're racist, if they're homophobic. That's going to add to this difficulty to trust, and it's going to get their nervous system activated and be very triggering. Also, dealing with the criminalization of homelessness, just seeing a trigger of if you see a police car, what that's going to do to your body, especially if you're a person of color. All of these things are adding to it. The stigma of being homeless, of mental illness, all activates the stress response. So part of becoming trauma-informed is also seeing this through a social justice lens. And I wanted to bring that up because you all are doing this work and you're seeing this. And this skill set and this best practice is going to help you connect back to those social justice roots. Because I bet some of the conversations at the tables had to do with social justice advocacy, and why you decided to get into this work. Okay, how are we doing? Good. So I always hate that when I go to trainings and the whole thing's about the problem and you're like, okay, well, we know what the problems are. How do we fix it? So hopefully that was pretty short and sweet. We're going to dive in now to the ACEs study, and we're going to hear from Dr. Nadine Burke-Harris. She's our first Surgeon General in California. I am also a professor at USC School of Social Work in their online program, and all new social workers are getting trained in this because, like Christine was saying, we had little bits and pieces of this at CARES when it was CARES. We didn't really know what to call it, but in the last 10 to 15 years, this is being implemented in agencies across the country. And we're seeing that staff burnout is less, morale's better, things like that. And now that we're really bringing trauma to the forefront through the ACEs study, and Dr. Burke-Harris is going to say more about this in the video, but providers are going to be screening for trauma starting in the new year. So it's going to be something that we need to be equipped to deal with and talk about in a trauma-informed way, because there's a lot that can happen when trauma gets brought up in a medical appointment or maybe in your car when you're driving someone around, and you want to know how to respond in a therapeutic manner and not re-traumatize your clients. So we'll go ahead and watch this video. Okay, so hopefully that was informative for you guys to learn more about ACEs from one of the foremost doctors who's really advocating for this screening to be routine. We're going to dive into it a little bit more at your tables. So on your tables, you've got a few handouts. If I could get the next slide, that would be awesome. We've got a little cheat sheet for ACEs, because I know that was a lot of information to take in. So this will be here for you to reference. And then we have a case study under that for you to read over at your table. And we're going to ask you to use the case study. There's also an ACEs quiz at your table as well. If you haven't taken it at some point, not here, but on your own time, it can be very eye-opening. We have all the School of Social Work students take it to have an understanding of how your own background could be affecting your work. So that's there for you to reference as well. What you're going to do is first talk about how aware are you of your client's adverse childhood experiences? Does it even come up? Are you just seeing that behavior and labeling substance use, mental illness, acting out in the lobby, can't keep their housing? Are you understanding what's beneath that? Are you aware of any childhood adversity? And then you're going to read the case example and fill out that ACE tool if you were filling that out on behalf of that client. And then you're going to also discuss at your table what strengths or points of resiliency can you identify in that case example. That's the other part of understanding ACEs, is that we look for resiliency and protective factors as well. Many of you who might be sitting here thinking, wow, this really, I experienced a lot of this, but I think I'm doing all right. You probably had a teacher, a family member that was there for you, someone who was believing in you. And I think it's always important to look for protective factors and resiliency when we have this conversation, and even with your own clients. So we'll give you time at your table. We're going to have 15 minutes to complete this exercise, and then we'll have our official break. We are running a little bit behind, so if you guys can just work quickly, I'll keep the time. Again, first question you're going to discuss is how aware are you of your client's childhood adversity? Then you're going to read the case example, fill out the ACE tool, and then discuss the resiliency and strengths for Zoe in our case example. Okay, so are you guys ready to nerd out with me? We are going to nerd out on neuroscience and brain development. I'm obsessed. My husband's always like, why are you listening to so many podcasts and YouTube videos about this when you do this all day long? But the reason I am is that it's just amazing the way our brains work and how we can access healing. Here's the thing. This work with trauma and even knowing what PTSD was, going back to working with veterans after our first world wars to now, we've had all these different interventions and ideas and ways to work with it, but really, this is a physiological disease that you can work with your brain and body to cope better with. When we have trauma, it doesn't ever go away. You're always coping, you're always living with it. I do all kinds of crazy things in the car after my accident. My body just jerks and I hit the ceiling and kick the floor and do all kinds of things that I'm just shocked about sometimes. And I've noticed when I'm stressed out in general in my life with my clients or whatever it is, my stress response is more difficult. And I always, again, my poor husband having to deal with, he's a safe driver, but I perceive threats differently after that car accident. So I am coping and living with that day to day. But I know what I need to do and have the awareness to breathe, to work differently with that. So I find that this neuroscience and brain science gives us a lot of hope for the healing and how we can heal our brains. So I don't want you guys to freak out about all these big words. There's no quiz at the end. I have a really simple summary slide in our next section of the presentation that I want everyone, when we get to it, to take a picture with their phone because it's just very basic brain science. But if you look at how all these parts of our brain that are all working, I've got my little brain model here too, if anyone wants to see. It keeps falling apart, which I don't know what that means. I'll go ahead and pass this around. So I'm going to take you through the different parts of the brain that are affected by trauma and then do some demonstrations of things that we can do to access that area of a client's brain and our brain and work through it when it's happening. Usually with trauma, parts of our brain are either underactive or overactive, and there's going to be strategies for each type of behavior that's presented. So Dr. Nadine Burke-Harris talked about that fear center of the brain. That's in the amygdala. That's in the deepest part of the brain stem. It is what gets developed first in utero. It is that alarm system that's actually really useful. Like she said, if you're being chased by a bear, you want your flight or fight to come on. Sometimes even freezing is a protective thing that people's bodies will do to avoid getting hurt worse, for example. Everything gets processed through here through danger and threat. And clients who have really active symptoms are looking at you to see if you're dangerous or threatening, or the people walking in and out of the lobby. I see a few veterans in my private practice, and we have to work with what it's like to come from, a suburb of Sacramento into Midtown and East Sac. Very activating to be around all of the people in that part of our city for this individual that I see. And he's able to now, sound like simple things, but he can get there. He's early on time because he's military. Love that. I'm not. But I honor that in him because he wants to get into the lobby and feel safe in there and calm down and not have to deal with all of the uncertainties that can happen just in getting to the appointment. So with the different types of trauma responses, and again, we talked earlier about how you're going to start looking at your client's behavior differently. So when we say fight, usually we think of like someone actually getting in a fight in the lobby, for example. But what other ways do you think a client shows this fight response when they're interacting with you in a case management session or during health navigation? Aggression. Tell me a little bit more about what that might look like.
Being on the defense.
Being defensive.
Being defensive.
Yeah.
When you're trying to help the client and then you say something that can trigger, and the client becomes defensive when that is not at all what was intended.
Do you ever feel like you say something and they just take it way wrong? And you're like, whoa, I did not, those words didn't come out of my mouth. They probably got activated and triggered. So defensiveness, maybe even sometimes verbally abusive, and kind of just even fighting the help, resisting the help, right? That's, again, when that's happening, I want you to go, oh, okay, that's the trauma responsive fight coming out. Flight, running away. How many people have seen that? Literally, people might bust out of your office, right? Literally need to get outside. What other ways do you think fleeing or running away from situations is manifested in a trauma response and what you see in your interactions? Yes?
Not showing up to appointments.
Yes.
Everything going great, and then at the last minute, they just don't show.
Very, very, that's like the number one thing. So she said no showing appointments. I see that in my counseling practice too. I get ghosted sometimes. And I don't like it, it hurts. But that just whatever it is that they just they freaked out right before they got there and they just couldn't face it, even though you're trying to provide help and trying to set up the situation. And, in community mental health, I know we used to always talk about no-shows. And, I think we can all be honest. And sometimes when someone no-shows, we're kind of happy because maybe we're burned out and we need a break. But it's also, what does that mean? What's going on with that client? And how do you reach out to address and normalize that flight is a normal trauma response? And that's important to be able to say and acknowledge, like, I get it, it's tough. You tell me about what happened. What was the barrier that prevented you from getting here today? And see if you can work with them to accommodate a different schedule, a phone session, whatever it is. And again, I know you have to work with your supervisors and your agency policies on this, but this is where that accommodating a little bit while you're building the skills to be able to tolerate going to the appointment, getting there, being on the light rail, walking through the door, all that it takes to get to that appointment, which for people who aren't dealing with this might not be as big of a deal. Okay, so freeze. Give me an example of how a client behavior where they're frozen, they're checked out, they're stuck. Yes, disassociation. What does that look like? How can you tell someone's disassociating, would you say?
When they're sort of looking at you very politely, they're not sympathetic, getting moved to them, response from them, but they're still physically trying to.
Right. So you notice in their eye contact, kind of a blank stare, can tell they're somewhere else. Trauma-informed skills would have you stop and acknowledge that, recognize that, and try to bring them back into the room and regroup with what you're saying. Because if you just keep talking and they're floating above the room and looking down at you, they're not going to remember anything that you told them. Submit is the fourth one on here. We don't always talk a lot about this. This is where a lot of accommodating behavior comes in, which happens a lot in social service settings and relationships. So clients might say yes, they want something because they're trying to please you and they're accommodating, what they think they're supposed to be doing to get into a certain housing program, whatever it might be. So this ability of submitting to power and authority can be a learned trauma response. This happens a lot with people who are sexual assault survivors. A lot of people will say, why didn't I just fight? Or why didn't I beat the person up. Why did I freeze? Why did I submit? Well, submitting to someone that's attacking you can actually help keep you safe. So in the context of a case management session, if a client's accommodating or submitting to you, they're trying to stay safe and not make you, get mad or get activated or in your survival mode with them as well. So you want to check in about that and recognize that. I had a gentleman the other day in my office. I have a window where the sun's coming in, and we were getting into some really deep stuff, and the sun was like really beating on his face and like making him really uncomfortable. And I said 2 or 3 times, "Do you want me to lower the shade?" And he said no every time. And so I stopped and I said, "Do you see what you're doing? You're accommodating so that I don't have to get up and move the shade, but you're sitting here needlessly suffering and uncomfortable." And he was like, "Oh, wow, I do that all the time." Yes. So we want to kind of call that out. Good examples there. So again, the goal for trauma-informed care is to reduce the hyperarousal and the reactivity to the triggers. Okay, so we talked a little bit about how do we notice activation happening. I like this word activation. We often will label client behavior and say, they're off the chain today, they're tweaking, they're this, they're that. But really what's happening is that they're getting activated in their stress response. And that is a really neutral, nice way, I think, to talk about it. And it happens to us. Like, I was a little activated coming here this morning. The parking stressed me out. I was nervous about talking in front of you guys. My body was doing all kinds of activation, especially in my stomach. That's where my body gets the stress response. So we need to all be aware of that and aware of our own activation. And just to get a little more into, body language, eye gaze, muscle twitching, tension, and breathing changes. So all of that is nonverbal, right? So you want to be really looking at your client's body and seeing if you're noticing breath that's only stuck up here, eyes switching back and forth, looking down a lot, not able to maintain eye contact. And they start to shift in their chairs, in their seats. That means that they're starting to get into a trauma response. Maybe they got triggered by something that you said. This is when you want to stop and do a grounding technique. Okay, so we're going to do a demonstration of a grounding technique. Would anyone like to volunteer to be a client that's activated in their stress response, and I can demonstrate the grounding technique? Okay, so I'm going to just start this interaction. Be someone who's getting activated in those ways in your body. So muscle twitching, eye contact, you know what it's like when somebody's uncomfortable sitting in front of you, okay? So I'm going to notice that, do a grounding technique.
Want me to start?
Yes.
Okay.
How you doing today?
Fine.
So I'm noticing that you're look a little uncomfortable. You got a lot going on in your mind? Okay. So before we get started talking about your case plan, your case management goals today, I thought maybe we could do a little breathing exercise just so we can both kind of calm down. I know it was stressful probably getting here today.
Yeah, I had to catch the bus, had to catch 4 buses. And my goodness, I didn't eat breakfast. I'm hungry.
Oh my goodness. So pause button, I would go get her a banana if we had more time. Wow, well, it sounds like it was a lot to get you here today, and just the stress of the bus and the people, everything, just it gets into our bodies. So
My back hurts. Oh my God.
yeah, you feeling the stress response in your back. Yeah. Okay, well, let's try this exercise and see if it can help us focus a little bit better in our session today. Okay. So I want to just invite you to get comfortable in your chair and really feel the chair, the back support, feel your feet on the ground. Good, good. And if you want, you can close your eyes. You don't have to.
I don't want to close
That's
my eyes.
okay. That's a choice. No problem. You can stay looking at me, or you can look at a point on the ground. Just want you to have your eyes try to calm and focus on a spot on the ground. Good.
I like your shoes. Those are cute.
Oh, thanks. Yeah, you can. The shoes are a good spot, and we can keep your eye gaze there. Okay, so we're going to go ahead and invite you to take 3 deep breaths. And you're going to inhale and exhale. Inhale and exhale. And notice as you breathe in this next time, inhale, where does the breath go in your body?
My chest.
It's in your chest, okay. So we're going to want to try to work to bring that breath down into more of our diaphragm, into our abdomen as we go through this exercise. But right now it's in your chest, and it's good that you're aware of where the breath is in your body. So now I want you to just try to breathe normally as we do this. I want you to draw your attention to your feet. We're going to do a mindfulness exercise just to ground you here in this moment. I want you to wiggle your toes and then kind of push each toe one at a time into your shoes. And I want you to feel your shoes on the ground, noticing that the ground is there to support you. And now moving up to your legs. Notice the chair supporting your thighs. Really focusing on that contact between the chair and the thighs. Now going up, feeling the chair supporting your back. Now that we've grounded into each part of our body that's touching the ground or the chair, I want you to try to take 3 deep breaths again. And this time, let's have you put your hand on your stomach where it's comfortable. And I want you to, as you breathe in, watch your hand. So inhale, abdomen fills up with air. And exhale, empties out. And inhale, noticing your hand move as your body fills with air. And exhale, as your hand goes back down and the air empties out. Good, I can see you're really getting into your diaphragm, which is activating the parasympathetic nervous system, the part of your body that tells you that it's okay to be calm and be able to concentrate as we go through the rest of our session. So when you're ready, you can open your eyes and look around. So, you feeling a little less stressed in your body after that?
Yes.
Okay. So now we can talk about your case plan.
Yes.
Oh, and I'll get you a banana. Okay. Thank you.
Thank you.
Thank you. How many people will stop their interaction with a client and do deep breathing? Just honest, real. Anybody? Got one over here, 2. Okay, 3, 4 back in the back. So it's going to take some practice to introduce these things, but when you make it part of your session, clients will start to, and you provide some of the psychoeducation about what's going on in their bodies, clients will start to even say and note it. They'll say, I'm activated today. They'll use those words. Okay, let's do one of our techniques. Okay, so moving on into the hippocampus. This is the memory center of the brain. This is where memories get a timestamp. A lot of trauma doesn't always go along a timeline the way that maybe someone else who was around remembers it. It can get really jumbled up. It can be really hard to recall things that happened, especially in the early childhood. But even just having memory issues is just in short-term memory, in terms of keeping track of all the things you're telling your clients to do. The memory issues are a real thing for trauma. And over time, if those stress hormones are there in the fear center, your brain's getting inaccurate, sometimes signals, and so then the memories are really confused, and then even just the part of the brain that helps you to remember can be underactivated. So this is where feeling safe in the present moment when there's not an actual threat is really important. Again, understanding, we'll have some slides in the future of the presentation to know what your client's triggers are and what their stress responses are. But if someone's not feeling safe, like let's say that this didn't work and she's really having a tough day and she's just not feeling safe or present at all, we might want to try another technique to increase the sense of safety, self-soothing and self-regulation. So before I do this next demonstration, if everybody could put their hands in front of their eyes, both hands in front of your eyes. And I want you to look at me and maybe spread your fingers a little bit so you can see me. And I want you to notice that even though you can see, my navy sweater, my red lipstick, whatever it is, first you're seeing your fingers. So that's what I call the trauma lens. So when someone gets activated, there it is, it's on. They're seeing the trauma and then what you're saying. So you can go ahead and put your hands down. So remember that's a helpful tip, even helpful to do some psychoeducation with clients around that. Okay, so the next demonstration comes from Peter Levine. Again, if you want to keep nerding out on this, you can Google that and watch some YouTube videos. So this one I would invite everyone to do if you're comfortable with me. Again, choice and options. What you're going to do is I'm going to have to put the mic down and I'll talk loud. You're going to take your right hand and put it under your left armpit. And then you're going to take your left hand and put it over your right arm. Okay, good. Just take a couple of deep breaths here. What does this feel like in your body? What are you noticing? What does this feel like in your body? Like a hug? Warm? Comfort? So you're self-soothing when you do this. It's funny, I feel like coaches will stand like with both of their arms in their armpits, like that's a stance. And I thought, wow, maybe they're trying to calm down and we just don't know it because they're stressed out about the game or the team or whatever. But that's something that you could do sitting in your chair of your office. You could encourage clients to do that. What that's doing is connecting to the nerves in your body that activate your parasympathetic nervous system, which tells your body it's safe here, I can rest, I can digest. These are all things that our body needs to be able to even feel calm at all. Also, when you think about soothing a colicky baby, an infant, you would swaddle and maybe even wrap your arms really tightly around them and rock them. That's going to activate self-regulation, self-soothing. Another quick one is to just place your right hand on your forehead, your left hand on your heart. We'll take 3 deep breaths here. And then move your right hand onto your chest, your left hand onto your stomach. 3 more breaths. Anyone notice anything in their bodies with that one? What'd you notice? Yes.
You can kind of like feel where your breath is like traveling throughout your body, like while doing that exercise, like watching your hand like rise from your stomach and go to your chest and exhale.
Very good. So he said he can recognize where the breath is going in your body. So that's a really good one if someone's breathing up here, right? This is going to keep someone activated. If the breath is here and tight, that's fight, flight, or freeze. I got to run from the bear. Breathing down into your abdomen, to your diaphragm, is where you activate the calming, soothing part of your body. So that's a great insight. Another thing that's really interesting about how trauma gets stored in our bodies is that the psoas muscle, which is this really crazy muscle that like wraps all the way around your hips and the front part of your abdomen into your low back, into your sacrum. Client example talked about low back pain. That's the muscle that's needed to run from a bear. So if it's tight, it pushes up against the diaphragm and it gives us difficulty to access that. How many of us have, that low back pain or those shooting pains, like when you're stressed out in that area? A lot of people store a lot of emotion in their hips area. So that's why it's so important to be able to activate the diaphragmatic breathing so that you can tell the muscles in your body, we don't need to run from a bear today. We're safe in this room with this case manager, health navigator. Okay, so we're gonna skip ahead. If we have time at the end, I'll do the next demonstration, but I want to make sure you guys have enough time for the next exercise. So I'm gonna go through these slides without the demonstration and then we'll circle back. So the insula, this is a really fascinating part of the brain. This is kind of the hot topic in neuroscience right now. This is where this interoception and proprioception gets clouded with traumatized individuals. So it's a little teeny part of the brain that gives you this ability to connect with your body and your internal sensations. Many trauma survivors are really disconnected from their bodies, and we're really trying to access the body to calm the nervous system. The other thing is that balance and spatial awareness can be affected. I don't know if you guys have noticed if you're really stressed out or activated, if you drop stuff a lot or you feel more clumsy, that's usually a sign of the stress response in your body. Also with interoception, this is where when that trauma lens gets activated, when you think you're doing a great job, you're just trying to give some information to a client, move through your interaction with them, and then all of a sudden you lost them. You don't know where they went. They got triggered. You don't even know what you said to trigger them. That might be when their perception is being affected by the trauma in their brain. And sometimes too, they might tell you like a story or an example of something that happened that doesn't totally make a lot of sense from your perspective. That might be because, and you might want to ask them, how was your body feeling when you had that interaction with your neighbor? So that's where that perception part, it gets really affected by trauma. So when we have an overactivated insula, this is when we see a lot of emotional reactivity and outbursts. So these are your clients that are coming in mad all the time, acting out in the lobby, acting out, in their new housing situation. Everybody's pissing them off. They're just having a hard time. Then the underactivated is more of the people that stay numb or disassociated or are seeking ways to be numbed out, which would be, relapse, things like that happening. So again, we want to reconnect the body and mind so that we have less emotional outbursts and disassociative symptoms. So for an overactive person, you want to let them move. We have so many rules and regulations of like sit in the chair and don't leave the room and don't do that. Just sometimes knowing that you can leave will calm you down. So I'll have clients that are really overactive in my office, just start walking in my office and let them walk towards the door. Most of the time they're not going to leave because you've given them a choice and an option that it's okay to move. If you, let's say you were taking a client to a medical appointment and the lobby is really crowded and loud, or you have to go to like the emergency room, let them walk around the lobby area. Encourage them to do it in a mindful way. 1 foot in front of the other, feeling your feet in your shoes, doing the breathing. So someone who's underactive, you can encourage them to tap, again, all the nerves in your face, your throat, your collarbones. You know, when we do our CPR training and we hit someone on their collarbone and say, "Are you okay? Are you alive?" It's because there's a lot of nerves there. So if someone is starting to like disassociate or check out, you can ask them to tap their collarbone. If you could do that with me and just notice what that feels like. Tapping eyebrows, temples, facial bones. This will help get you back in the moment, get you less numbed out and disassociated. Rocking is also a good thing and is okay. Sometimes people are self-conscious about rocking or moving, but you might see clients do that naturally because they're trying to self-soothe. That activates self-regulation. Also, having a client have some sort of an object they carry with them, like a rock or a crystal or some symbolic thing that means something to them, and having that in their pocket so that they can, you know, hold this, touch it, use the putty. That's going to help them stay aware. And really, the simple thing of the feet and the shoes, that is such an effective way to get back into your body. Most people, feet are a neutral part of the body. You'll want to find out, make sure that it is for your client, encourage them to be aware of their feet. Okay, prefrontal cortex. So guess what? In your job, a lot of times your people's prefrontal cortex, right? You're helping them make decisions, get through life. Eventually, we'll talk more later in the slides about empowering and skill building. But sometimes when someone's in a crisis, they need somebody to activate and be that prefrontal cortex, and that's okay in a crisis moment. Over time, we want them to be self-aware, do these techniques to have a down-regulated, calm nervous system, and then be able to concentrate, make decisions, be empathetic, be self-aware, and be able to build relationships. So that's all the stuff, prefrontal cortex, which also, some people don't realize this, that the prefrontal cortex is not fully formed until the age of 25. So if you think about when a lot of people's substance use disorders will start in teenage and early adulthood, or if you are dealing with a young person, maybe a transitional age foster youth, with all the trauma as well compiled, their brain is still developing in that prefrontal cortex. We like to think when someone's 18, they should know how to do everything, right? We know that's not true. So that's something to keep in mind, and being supportive of clients and their access to their brain. This is the thinking part of the brain. Okay, we're gonna skip this demonstration for time. The Signalet is how we work through conflicting thoughts, self-regulation. When we have trauma, this is underactive, and it can lead to impaired self-regulation and judgment. So how many times have you guys gotten frustrated with your clients when they just seem to make like not the smartest decisions over and over again? Can be really hard. It's hard not to judge when you see that happening over and over again. If there's trauma on board, this judgment center is definitely affected, and they may need a little more practice and skill building in this area. Also, therapy is really helpful with this part of the brain development. Of course, I am biased. I am a therapist, so I think therapy's great. I think everyone should go to therapy. But just so you know what hopefully some of your clients are in therapy as part of their care plan, that you know what the therapist is working on. And I encourage you guys to ask the therapist what skills they're giving to the client so you can reinforce them. But these two things of having painful emotions or distressing thoughts happens all the time. A lot of time we're just trying to run from extremely painful emotions, even clients who are suicidal. A lot of times it's that they're just saying, this emotional pain is so intolerable and I want it to stop. So when we think about skills around that, the idea of doing the opposite action is really helpful. So this comes from dialectical behavioral therapy, and it's just an acknowledgement of, like, if you're feeling a certain type of way, you just do the opposite thing. That's going to snap you out of this cycle of painful emotion and distressing thoughts and get you thinking on a different path. Also, having a client hold ice cubes, if they're really emotionally dysregulated, will also bring them back into their bodies, because it makes their brain go, oh, I'm feeling something different in my hands, and I'm feeling kind of the discomfort of the cold. Very useful. Splashing water on your face, water on the back of the neck, washing your hands. I like to do that between clients personally, because that helps me kind of symbolically let the last session I had go, kind of wash it away, start fresh with the new one. With distressing thoughts, it's really important to be able to help clients to notice what the thought is, observe the thought in a detached way, so they're not believing like the negative self-talk that might be there, and then reframing it and giving them a mantra like I am safe to say when they're starting to feel the distressing thoughts. Finding a mantra that really resonates with them is important. I've got these little pocket mantra cards that I'll have in my office. I'm gonna have you pull one out. Okay, what does it say?
So the card says, I have great ideas.
Awesome. So something simple like that. How does that change your emotions when you think you have great ideas? If you were sitting there thinking, oh man, this sucks. You have a different thought, it changes your emotional state. Journaling, thought records, very helpful. And again, asking the client's therapist what they can do to reinforce it. These are simple things you could also make, and you could just have them, take one before they go to that big, court hearing, or they have to have a tough conversation with a neighbor or their housing specialist. They could have that and read it to get out of the distressing thoughts. Okay, how are we doing? You just became a neuroscience nerd. Yay. All right, so now we're going to give you an opportunity to work with these new ideas that you've learned about brain science, and we're going to actually build a brain with the tools on your table. So have a little creativity and movement. We're going to watch a video to describe what to do. We're going to have to double up a little bit. So the tables kind of in the middle section of the room if your table has a baggie of pipe cleaners and things, raise your hand. Okay, so if your table doesn't have one, I'm gonna have to ask you guys to squeeze in with each other, which I know is gonna be tight, but let's go ahead and make those moves now. If you're not at a table with a baggie, find one where you can, squeeze in. Okay, so trauma-informed care, I've been talking about this all morning. I'm seeing some people move and stretch. You can go back to your table. You can stay where you're at. I'm just going to keep talking. Again, take care of yourselves. Maybe somebody needs a time in the self-care corner. It's been a long morning. We're almost there. Appreciate your patience and attention. So the principles of trauma-informed care are safety, choice, collaboration, trustworthiness, and empowerment. All really great words, right? And in this next section, we're going to talk a little bit about what trauma-informed agencies look like and what trauma-informed staff look like. Ideally, if you were to say, go back to your agency and say, oh my gosh, I learned this new care model, I think we should implement it. It takes about a year for an agency to adopt this care model and have the cultural change that needs to happen within the organization. And we are happy to help support that. I know I am. I consult and go into agencies and implement this. And it takes time. I implemented this model at the domestic violence shelter I was running, and it brought up a lot of stuff because we had a lot of kind of forced empowerment going on with our clients, and kind of recreating that batterer-victim relationship in our shelter that I was running. So we had to really unpack this. What we found was that staff were less burned out. And that team, interestingly, I had a lot of superhero social workers and martyrs, and they would not take time off when they were sick. They thought they had to go to work no matter what. And when we implemented this, we started seeing people actually use their PTO to stay well and be well. In other agencies, you might see people using too much or being sick too much because of the toxic stress. So these are little ways that we measure if this is effective or not. But in these definitions, we've talked a lot about emotional and physical safety, making sure your clients have choice, and that you're collaborating with them in what their care plan is. It should be a collaboration. It shouldn't be something where you have all the power, you're telling them what to do. Trustworthiness, we talked about how clients who've experienced trauma, they have a hard time trusting people. So how do you build that? You need to be really clear, consistent, and have interpersonal boundaries. Boundaries, boundaries, boundaries. We have to have those. They will keep you in this field for a very long time if you can have boundaries. I believe we're going to have another training about boundaries at some point this year, right, Christine? So we can dive into that a little bit more. And then prioritizing empowerment and skill building. This is really important because sometimes what can happen is there can be some learned helplessness or forced empowerment going on with clients, especially in a case management role. And eventually you might, go along with them to an appointment the first time, then you teach them how to take the bus or use transportation services to get there. You help them figure out where to find their doctor, whatever it is. But eventually they're doing that on their own. And that's really important to show that we're actually empowering clients. All right, so how does this look like in an agency level? These are just examples. You guys may be doing some of these things at your agencies already. These are just ideas, maybe quick and expensive things that could get implemented. Again, the environment needs to be predictable, clear expectations about client behavior, really, really important. You need to have structure to your interaction. So if they come into your office and you start out with a check-in, do that every time because they're going to know what to expect from you. Using person-first language. So instead of saying that angry client, you would say a client experiencing anger. Do you see the difference there? Less stigmatizing. Also showing that anger is a neutral emotion and it's a state of being that can be there one moment and be gone the next if we do our techniques. Yes, question.
I would love us to stop calling clients case.
Yes.
So my goal for the last 30 years is to stop calling a client a case.
Yeah. A case, a number. And we'll see in the next slide that kind of feeling like a number is re-traumatizing for clients. Definitely using their clients' names, not referring to them as their mental health diagnosis, their substance use disorder, really seeing their humanity. Very, very important. Thank you for saying that. Having a calm down zone. Have that little corner over there. Took me 10 minutes to set it up. Maybe there could be something like that in a random room in the clinic or in someone's office. It should never be a punishment, but a choice. So if you saw someone getting agitated in the lobby, Maybe they're having a day where their nervous system is just way activated. They need quiet, they need calm. If you have an area like that, or even in your office, get some of the putty. Anyone been using the putty today? Good, very helpful. Rocks, different textures, stress balls, those little smushies that kids like, all those things are sensory, and tactile will help calm the nervous system as well, and having relaxing music on. So this is where we start to shift the paradigm. I'm not going to spend a lot of time on this slide just because we are really talking more about your individual skills as staff with clients. But when trauma-informed care is implemented, we see a vigilance in anticipating and avoiding institutional processes and practices that re-traumatize clients. So now that you've got this awareness, let's say you're in a staff meeting and somebody says, we should really change this or that or move this around. I want you for a second to put the trauma lens on, to put the fingers in front of your face and see the trauma and see, like, gosh, if we block that entrance or that exit, that might make someone who has PTSD feel like they can't get out if they need to get out. Or if I move my desk in my office and I can't get out of the door. All of those changes that happen sometimes where we don't think through how it's going to impact clients. So now that you have this awareness, you want to start to look at policies and practices through that lens and be a voice to advocate for that. So here's what happens when we don't shift. Re-traumatization happens. This is the part where my advocate part of me gets really stirred up and activated, because, oh boy, how many of us have experienced these things if we've had to be on the side of being a patient in a hospital? I'm a very annoying patient because I'm a social worker and I advocate. Our clients don't always have the voice to do that, and that's a lot of times where your role comes into play. Some of these things are just to begin to look at and bring up. I'm going to just highlight a couple of these. Having to continually retell their story. So depending on what your role is on the team, you may not need to know the specifics of that client's trauma. You may need to know what their triggers are, but they don't need to be telling you their whole sexual assault story. That's for their therapist. But you need to know there was a sexual assault. You need to know the headlines. The doctor might need to know the headlines. But that having to retell it is really difficult, and clients will talk about that on patient satisfaction surveys about how difficult that was. Because sometimes they'll tell you their trauma story in a really detached way too. I don't know if you've noticed that, where they just go through this litany of things where they have no emotion. They're kind of just blah, and you're going, oh my gosh, but you got to fill out this paper and get through this assessment or this session. And we don't always stop to go, wow, you just shared a lot with me today. How are you doing? Let's check in about this. The other thing is too, people don't want to be pitied either, especially those that have high ACEs scores and they have been resilient and have had a lot of those supports. They don't want to be seen as their trauma either. They might want to be seen as a survivor of domestic violence rather than a victim. You see the person first language there as well. So we've got being treated as a number here. Sometimes in medical settings, having to fully disrobe is very triggering for clients. Again, how can we work around that? If you have to have an anal exam, there's ways to cover up the rest of your body. You don't need to be completely nude while you're having a very embarrassing exam, right? These are the things to empower clients to speak up, to say, I'd like to be more covered up than this. We talked about the labeling. Also on the relationship side, if there is non-collaboration or trust violation, you're going to erode that emotional safety really quickly. And that's where the power and control dynamic gets recreated in the helping relationships. So you really want to watch out for that. Okay, so what does it look like from client to staff? This is where I want you guys to start to think about how maybe you could bring some of this up with clients. You want to know what their triggers are. If they can't sit in a room with their back to the door, switch it around. That would be a trigger. Also, list ways that what it shows up when they're stressed or overwhelmed. They might say, I start to fidget a lot, my legs start to move. So then when you start seeing that in their body, they're getting activated. And then we want to know, what are the strategies and responses? If they don't know what those are yet, maybe the therapist can help you with that. But you need to know what's helpful when they're upset or overwhelmed. Some people need a lot of eye contact and attention and soothing, and others maybe just need a few minutes alone, or they need to be allowed to go walk around the block and come back to your office. So you want to have a strategy for all of that. And then who are the people in their support system that they can go to and they can feel safe with? There may be someone in the agency, maybe that person is you, that the client does trust and feels safe with, and they may need your assistance when they're dealing with someone an interaction that might be triggering for them. You need to know what their level of definition of emotional safety is. Motivational interviewing techniques are really great. We were just talking about that. Another great training that I think we're going to be offering as well, to give you real examples of how to put these things into action. We talked about the language as well. Another example, we talked about people who are experiencing homeless rather than homeless person, having a hard time getting their needs met rather than attention seeking. I worked in the emergency room. The heart attack in room 12, that's just a very medical model, right? And I would say, oh, thank you. Or the schizophrenic in room 12, because I was on the mental health side. Oh, you mean Mr. Jones, who's living with schizophrenia? Yeah, I'll go over there and do that assessment. So sometimes we have to model the person first language if we're working in a medical model setting. Another one is that client's manipulative. Well, maybe they're just really resourceful at getting their needs met. So starting to switch that language around, totally different experience for you and the client. Okay, I'm gonna do this fast. All right, so how do you do this? How do you become trauma-informed in your role? It really starts with you, self-care, having your own self-care plan, understanding what vicarious trauma is, moral injury, we'll go over that in a moment, and understanding your own physiological response to your own triggers. Very important. Okay, so here's the slide that sums it all up, okay? All that brain stuff we did, it's all right here. So if you want to take a picture of this slide, feel free. So you look at how the brain is built, survival state. The client is thinking, am I safe? Emotional state, limbic system, am I loved? Do you care about me? Am I just a number, or do you really care about me, case manager? Executive state, what can I learn from this? So the stuff on the right is the things that you want to be saying to clients and how your interactions want to feel. So you're telling them, you are safe. I do care about you, and I'm here with you, and we're here to problem solve and find a solution. Okay? So if you don't work at that level, if you don't take anything else away from today, take this away. Because if you keep talking and telling them that they need to go to the WIC and the welfare and go here and do this and do that, and they're not feeling safe with you, they're not going to hear a thing you say, right? So start safety, connection, care, and finding a solution. And it's we can find a solution, not I'm telling you what to do. All right. Again, we've talked about this. Instead of asking what's wrong with you, what happened to you? What happened in those early childhood experiences? How are you feeling? What's making you feel this way? What's right with you? That's a nice way to find a strength. What's going well in the session or in that day? You want to model what you want. You need to speak in a calm voice. You need to be breathing. How many times, when someone yawns and then you yawn? If you take a really deep breath, your client will take a deep breath, sometimes without even having to say anything. So you want to be breathing. You want to sit with your feet grounded on the floor when you're interacting. Be funny. Incorporate humor. I know this group does that. And you need to do that with each other too, and try to have a little levity and fun in what you're doing. Active listening. Also, if you were, instead of coming over and to a client and saying, we're going to go over here right now, and I'm going to take you over here. Hey, when you get a chance, can we get up and walk over this way? Totally different. I'm getting to eye level and I'm not towering over the person. If you have to give feedback, maybe they're acting out at their housing or they're about to get kicked out, you need to find something positive they're doing well and then go into what they need to correct. Okay, so vicarious trauma. We've talked about having our own awareness around our trauma, what we've been through in our lives, but we can experience clients' trauma, secondary trauma, vicarious trauma, just from doing this work. I know some of you have felt this and dealt with it. You've dealt with burnout. Sometimes the compassion fatigue is there as well. Vicarious trauma can get to a level where you start to really experience and interact with a client out of their trauma. So that's when you get really fused and that survival mechanism is kicked in and you're really doing a disservice to both of you. And self-care practices are a way to reduce that. Okay, so this one, moral injury, very important. This is what happens at the system level when we know the system we're working in can be very stressful and challenging. And this can be felt at all levels of an organization. I think sometimes as staff, we don't really think about the stress of like what a new funding law or policy is doing to the executive director of the organization. And then like they say, you know, a certain thing rolls downhill. This happens. The people in management, the leaders, they're feeling the stress of this moral injury. And the definition of moral injury, I want you to pay attention to this. Perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. So this is all the stuff that's outside of our control. This came from studying veterans, as a lot of PTSD studies do, where veterans who were not involved in combat, but had, were in other services like providing medical support, and they weren't on the battlefields, would still come home with PTSD because of bearing witness to these things. So I say this just to acknowledge that there's bigger pressures at play, and it's not a lack of resourcefulness or self-care on individual staff's part that always adds to these issues of burnout and toxic stress in workplaces. It can be that system stuff that maybe even your boss doesn't have control over. And that's like the 1,000 little paper cuts that get to you over time of dealing with these really difficult systemic issues. So we need to acknowledge that when we have these conversations around trauma-informed care, and maybe have some compassion for each other, and even across agencies. You guys are all dealing with this. You guys are having to see this news stories about what's going on in Sacramento with the homeless population. Oh, don't ever read Nextdoor and hear what people say about homeless people on there. Ooh, I have too. I'm like, we need a social worker or case manager to moderate this thing, because it's horrible what people, that gets to you at your soul level. I don't know another word to say. That's the word I use, is at that soul level. So you got to take care of that. How do you do that? We're almost out of time. I'm going to talk really fast. These are all the signs and symptoms of vicarious trauma that you might see in each other or in staff. This is when you need to reach out and get some help if you're having this level of symptoms, because your symptoms look like the diagnostic manual of PTSD if you have vicarious trauma, right? So you got time to get some help, time to put it into practice. How do we do this? Peer supervision or supervision led by a clinical supervisor. Very important. Some agencies have this, some don't. If your agency's not doing it, get a group together and support each other. Support across agencies, I think, would be even better. Community building activities with colleagues. Do stuff together, build relationships. You guys are that straw, that support to one another. Simple things. This is quick little funny CARES story. We used to, on Friday afternoons, do a dance party at 4:55 or whatever it was, and we would just put music on and dance in the office. It was so fun, just to end the week on a good note. It was great. Little things like that to bring back will really be helpful. And we included all levels of staff, not just the outreach or behavioral health staff. Keeping a process journal, you need to externalize what you're experiencing. You need to write down your feelings. When those clients, you have a hard day and you can't stop thinking about them, your sleep is disrupted, you need to get it out. You cannot hold that in, and journaling is a really great way to do that. Employee assistance program or your health plan behavioral health. This is for you to get some therapy, for you to get some help, find out what your organization offers. Talk to me if you need any referrals. There's other great resources out there in the community. I am a huge believer in accessing what is there. Your organization pays for this, for you to access it. Think about doing it. What are your personal coping mechanisms? Do you have a spiritual practice? Do you go to therapy? Do you meditate? Do you exercise? Do you have therapeutic hobbies? Again, we're not using self-care to push past our limits, we're using it to honor our limits. So these therapeutic hobbies need to be in place, not just running around town, busy, trying to check off your self-care list. So we are out of time, so I'm gonna keep going, but I have a self-care plan on the table for you to fill out. You can do that while I'm talking. You can take it home with you. We have extra copies in the back to use this with clients. And we're gonna end on, you are human. I'm looking at all of you because I used to work with you, and I've done these things where you don't take breaks. You don't go to the bathroom. You will hold your urine for 4 to 6 hours because you're running clients around town. You don't want to stop and get stuck in traffic. You don't drink enough water. I know you don't. Drink water, which means you have to go to the bathroom. It means you have to take a break. And stop trying to save your clients, and don't withhold or deny yourself basic human rights at work. This is an old tired analogy, but when you're on a plane and they say, put your air mask on, you put it on yourself first and then your child. You've got to put your own air mask on and then your client, so you've got to take care of yourself. One more plug for things that heal trauma: getting enough sleep, having safe, healthy relationships, nutrition, exercise, mindfulness, mental health therapy. These are the things that heal trauma. These are the things our clients need and that we need as well. And come talk to me after too if you want business cards or you want, help on how to bring this up at the agency level, consultation around this. I'm happy to be of service. I would like to see every organization in Sacramento be trauma informed. How about that? We'll end on that. All right. Thank you, guys.